So today I'm going to talk about my favorite topic, which is breast cancer. And as we'll discuss, it's a relatively common disease, so I think many of you in this room have been touched by this disease. No one has been affected at some point. So the topics that I wanted to cover included what are the main risk factors for breast cancer. We know that there are certain genes like BRCA1 and 2 that increase a woman's risk. We know that having some benign breast biopsies can also increase risk. And also breast density, which women are learning more about as they get their screening mammograms, is also an important risk factor. We'll talk about ways to detect breast cancer early and also ways to prevent the disease. And if there's time, I'll talk about some research that we're doing to help increase awareness and risk assessment for breast cancer in the primary care clinics. First of all, we know that breast cancer is the most common cancer that we see here in the U.S. among women, as well as worldwide. There are over 200,000 cases diagnosed each year in the U.S., and close to 40,000 women per year also die of this disease. So it's only second to lung cancer in terms of cancer deaths among women. In terms of the trends in breast cancer, for incidence, we see that since the early 1980s, the incidence has been going up because we're detecting a lot more breast cancers on mammograms. But at the same time, since the 1980s, deaths due to breast cancer has gone down by up to 30%. And some of that is due to screening, and some of that is also due to better treatments for this disease. So this graph shows the main risk factors that can increase a woman's risk for breast cancer. So the strongest risk factor is having mutation in this BRCA1 or 2 gene. And then other moderate risk factors including some forms of benign breast disease and having more density in the breast. More milder risk factors include having more exposure to the hormone estrogen, and then also obesity and drinking lots of alcohol can increase a woman's risk of breast cancer. So if we look at all the breast cancer cases, it turns out that it's only about 15 to 20% occur in women who have a family history of breast cancer. So the majority, 70 to 80%, occur in women who don't have a history in their family. And in terms of breast cancers that arise in women who have a gene that runs in the family, it's only a small percentage, about 5 to 10%. And most of them are accounted for with the BRCA1 or BRCA2 mutation. So what do we know about the BRCA1 and BRCA2 genes? We know that it accounts for about 2 to 7% of all breast cancers that we see. And because it also increases the risk of ovarian cancer, about 10 to 15% of ovarian cancers. And in terms of how common these genes are in the general population, including whites and Hispanics and African Americans, it's about 1 in 400 who could test positive for this gene. But if you have any Ashkenazi Jewish background, it's much more common. It's about 1 in 40. And women who have this mutation have a lifetime risk of breast cancer of about 40 to 60%, and a lifetime risk of ovarian cancer of up to 20 to 40%. So this slide indicates who should get this type of genetic testing for BRCA1 and 2. So it depends upon how many relatives that you have with either breast or ovarian cancer, how old they were when they developed these cancers. Typically, if they were young, less than 50, then we think it's more likely to be hereditary. And then it also depends upon how closely related you are to those relatives. So direct relatives, mothers, sisters, and daughters, then the risk would be higher compared to more distant relatives. Also, if there's any male breast cancer in the family, so men can get breast cancer as well. And if you have Ashkenazi Jewish background, you need less of a family history. And if you have someone in your family that tested positive, then there's a 50% chance they can pass those genes to their children. So I wanted to talk about, so like I said, it is a blood test, or you could also do this genetic test with saliva. And if the test comes back positive, we know that a woman is at high risk for breast and ovarian cancer. most of the time, the test comes back negative. And if there is a BRCA mutation in the family, then we could say that that woman has an average risk for the disease. But for most families, we don't know if there's a mutation, so the woman may still be at high risk because of her strong family history. And then sometimes when we do genetic testing, we get uncertain results, and so that's why it's not always so straightforward how to interpret these results. It's not always clear that it's a positive or negative result. What's also important to remember is that a positive genetic test result doesn't tell you whether you're going to get cancer. It just means your risk is higher. And even women who have a negative test result can still go on to develop cancer in the future. So what we know about cancer risk in patients who have a BRCA mutation compared to the general population. So breast cancer risk is much higher, as well as ovarian cancer in women. But we also know in men or women who have a BRCA mutation that there is also a higher risk of cancer of the pancreas, a type of skin cancer called melanoma. And men who have this mutation also have a much higher risk of male breast cancer and also a slightly higher risk of prostate cancer. So it's not just breast and ovarian cancer. So for women who are found to have a BRCA mutation, there are options for screening for breast and ovarian cancer, including doing self-breast exams, having your doctor examine the breast, doing yearly mammograms. And because these women are at such high risk, we also recommend getting breast MRIs for screening. Screening for ovarian cancer is less effective, but we can do pelvic exams as well as ultrasounds and a blood test called CA-125. But in general, it's less sensitive than screening for breast cancer. And these women start screening at a much younger age, by age 25 or 30. So because these women are at particularly high risk for breast and ovarian cancer, they do also have the option of having surgeries to remove the breasts, which will lower their risk of breast cancer by up to 90%, and also to remove the ovaries, which can reduce the risk of ovarian cancer by up to 80 to 85%. And in particular, because we don't have good screening for ovarian cancer, removing the ovaries is very important because it's associated with better survival in these women. So like I said, these BRCA mutations are relatively uncommon. It's only about 1 in 400 that are affected. But other more common risk factors include, so when women get screening mammograms, a lot of them need to get breast biopsies if there's something abnormal in the mammograms. And there are some forms of benign breast disease. Even though it's not cancerous, it can also increase a woman's future risk of breast cancer. And this is one of the ways that we can estimate a woman's risk of breast cancer based upon the known risk factors such as age, a woman's race, when her period started, when she had her first child, how many direct relatives or first-degree relatives have breast cancer, and how many breast biopsies did she have. So based upon this risk profile, this woman would have a 5-year risk of breast cancer, about 3.6%. And if she lived to the age of 90, her lifetime risk would be about 28%. So in addition to surgery, there are actual medications that have been shown to lower a woman's risk of breast cancer. And the way that these pills work is they block the hormone estrogen because we know that estrogen is important in the growth of most breast cancers. So we call this chemoprevention. But it's not for all women. It's only women who have a high enough risk of breast cancer who are eligible for those pills. For premenopausal women, the only pill that's approved is tamoxifen. But if after menopause, there are at least 3 other pills that are approved to help lower a woman's risk of breast cancer by up to 50 to 60%. So we talked about the density of a woman's breasts on a mammogram, and that's what looks very white on the mammogram. So when women get screening mammograms, if there's a lot of white on the mammogram, it makes it harder to find the cancer. We also know that women who have more white on the mammogram have a higher risk of breast cancer compared to women who have mainly fatty breasts. So more than half the states in the U.S. now have mandatory reporting of breast density in women who are getting screening mammograms. So that's all the pink states. So New York is a pink state. We're not a red state. We're not a Hillary or a Trump state. We're actually a pink state. But that means since 2013, women who are getting screening mammograms are informed if they have dense breast tissue or not. So in terms of the current screening guidelines for average risk women, again, if you are not at high risk, you could start screening between age 50 to 74, and you could actually get mammograms every 2 years rather than yearly. But for women who are at higher risk, then they may need to start screening younger, and they may need to get more frequent screening once a year, and then maybe additional tests like MRIs if they have a BRCA mutation or a strong family history. So these are some different ways of screening for breast cancer, so including examining the breast, mammograms, which are just an x-ray of the breast. We now have 3D mammograms, which are a little bit more sensitive, and then also ultrasounds or MRIs for higher risk women with dense breast tissue who need more intensive screening. And insurance might not always pay for a screening ultrasound or MRI. You really have to be at higher risk to get that paid for by insurance. So just to show you what a screening mammogram looks like in a very young woman with very dense breast tissue, it can really hide a cancer, but on an MRI, it's really the most sensitive test that we have for detecting breast cancer. But currently, breast MRIs are only recommended in women with a strong family history or hereditary breast cancer, or women who've had prior radiation exposure to the chest. So there are also lifestyle factors that the American Cancer Society recommends for helping to reduce the risk of cancer. So maintaining a healthy body weight, which is a body mass index less than 25, eating at least 5 or 6 servings of fruits and vegetables every day, drinking less alcohol. So for women, no more than 1 drink per day, but men can have 2 drinks per day. And then in terms of exercise, having moderate physical activity for at least 2.5 hours per week can help to reduce the risk of heart disease as well as certain types of cancers. So we can think about dividing women into different risk groups. So there are women who have a strong family history and have a BRCA mutation. So for those women, we may recommend aggressive surgery, taking one of these chemoprevention pills, doing more intensive screening, and also focusing on the lifestyle factors. And then there's the more moderate risk group who meet high risk criteria according to the Gale model, which is a greater than 20% lifetime risk. So those women don't need the surgery, but they can take the pills if they want, do the intensive screening, and also focus on the lifestyle factors. But the majority of women, 80-85%, are in the low to average risk group. But these women still have a lifetime risk of 10 to 12%, but they don't need the surgery or the pills, but they can still do routine screening and the lifestyle factors that we mentioned. So I wanted to tell you a little bit about some of the research that we're doing so that we can try to assess a woman's risk of breast cancer more routinely in the primary care clinic. So what we've been doing is when women come in for their screening mammograms, we ask them a bunch of questions to assess their breast cancer risk. And if they meet high-risk criteria, we've developed these web-based tools called Real Risk for the patients and BNAV for their primary care providers so that we can give them more information to help them make decisions about how to manage their risk, so that if they need to see a genetic specialist or come to our breast clinic for specialized counseling, then we're better able to identify those women. So when we went to the screening mammogram, on Audubon, we recruited close to 3,000 women. The average age was 59. Here in Washington Heights, over 77% of the women are Hispanic. Only about 60% of the women had a high school education or less, and about 30% of the women had the dense breast tissue on their mammogram. And most of the women, over 70%, were getting yearly mammograms, and about a quarter of the women met high-risk criteria for either genetic testing or to take one of these chemoprevention pills. In general, breast cancer is more common among white women compared to minorities, but Hispanics and African American women tend to develop breast cancer at a younger age and sometimes more aggressive breast cancers. So this is what the web page looks like for Real Risk, and women can sign on online. It's available on your iPhone and tablet as well. And it's broken down into these different modules with different topics like understanding risk in general, understanding the breast cancer risk factors that we talked about, how to make your family tree to collect family history information, as well as information on genetic testing, the breast cancer prevention pills, and lifestyle factors that can also help lower your risk. And then once you go through all the modules, then it gives you a summary of what your own personalized risk information is based upon the information that you put into the model. This is just showing so we got a lot of advice from the women who were using these tools in terms of how they would like to see the information presented to them. So some of them like the idea of having a narrative with comics and audio. Some women just like to go directly to the facts, so a lot of the information that I gave you about the breast cancer prevention pills can also be presented in much more discrete information like this. And then if you needed definitions for some of these words like osteoporosis, you could also hover over those words to find out what each of the terms mean if you're not sure. And then one of the things that we want to do is put games in it to make it more engaging and interactive. So if you want to tell a woman that there's a 12 in 100 chance that she'll develop breast cancer in her lifetime, she can play this clicking game to find the 12 out of 100 women who are affected with breast cancer. And then when women are considering things like taking a breast cancer prevention pill or going for genetic testing, oftentimes there are pros and cons to doing these tests. And so we can also elicit what the patient prefers as well. And then finally, at the end, when the woman finishes all of the modules, she can then get a summary of what her risk is compared to an average woman. It shows her family tree from all the relatives that she put in, and it also shows what her preferences are for taking prevention pills or going for genetic testing if she's eligible. And then because the tamoxifen pill isn't always right for all women, we're also doing other studies to try to find safer and also effective agents for preventing breast cancer. So the things that we have been testing include things such as green tea, vitamin D, omega-3 fish oils, which may have some benefit for the heart as well as for preventing breast cancer. And then there are medications that we use for heart disease and diabetes, like aspirin and metformin, that are also being actively studied for the treatment and prevention of breast cancer. And then of the antiestrogen pills, we're also looking at alternative ways to administer these drugs, like giving lower doses or giving topical forms of tamoxifen to see if it can help reduce a woman's risk of breast cancer. So just to conclude, we know that breast cancer incidence has been going up, but deaths due to breast cancer has been going down because of screening and better treatments. We do have options available for early detection and the prevention of breast cancer, but we know that some of these interventions like genetic testing and chemoprevention is still largely underutilized in the clinics. But one thing to remember about breast cancer, it is a very treatable disease. Most women are going to be cured of their breast cancer. But because it's common, we also know that there are ways to prevent this disease and prevent patients from having to go through the treatment of breast cancer. So just to say that for those who are interested in learning more about their risk of breast cancer and what they can do to lower their risk, we have some information about the tools that we're testing as part of a clinical study.